Hello everyone, welcome back. So today I'm going to start with the leftover topic in the fibro-osseous lesions, and in detail we were discussing about fibrous dysplasia. We discussed monostotic, polyostotic, craniofacial. Now the only thing that has been left out to discuss is cherubism. Once I finish cherubism, we finish a major 10 marker, that is your fibrous dysplasia. So once we finish cherubism, we will move on to the other lesions. So first is let's go a little deeper dig in a revision of the fibrous dysplasia. So we discussed what fibrous dysplasia is. So fibrous dysplasia is when the normal bone is replaced with fibrous tissue. Okay, that is called as fibrous dysplasia, and the bone becomes more elastic. We discussed then there are two types, actually four: monostotic, polyostotic, craniofacial, and cherubism. So in monostotic we discussed that one bone is involved, and in polyostotic we discussed two or more than two bones are involved. Then in polyostotic we also discussed about two syndromes, Jefferson syndrome and McCune syndrome. So then we discussed something called as cafe Ule. What about this phenomena occurring in these two syndromes? We discussed that as well, and then we discussed craniofacial form, where there are this fibro-osseous dysplasia occurring in the face and the cranium. Then now what we are going to discuss in detail is cherubism. Okay, all this we have discussed earlier. Let us directly go and take a deeper dig in cherubism, what cherubism is, right? So just a second. So cherubism is a familial kind of fibrous dysplasia, and it is also a type of disseminate juvenile fibrous dysplasia. So this is the other name, that is your disseminate juvenile fibrous dysplasia. So cherubism is a rare developmental jaw condition. So cherubism is a rare and it is a developmental jaw condition that is generally inherited as an autosomal dominant trait. Okay, so cherubism is a genetic condition and it is developing in the jaw and is inherited as an autosomal dominant trait. So it is a dominant trait. Then coming to its penetration, it has high penetrance but variable expensivity. So let's see the predilection. So it is more in males than in female and characterized by significant destruction of jawbone. So here you have a destruction of jawbone, unlike your monostotic and polyostotic where there was expansion but no destruction. There is swelling in the lower part of the face. Now coming to the etiopathogenesis, mutation is there is a mutation in SH3BPL gene on the chromosome 4p16. Normally protein encoded by this gene is functional in signal transduction pathways, increasing activity of osteoblasts and osteoclasts during normal tooth eruption. So what is happening here is that there is a mutation in this gene called SH3BPL. I think you can remember BPL. You just have to remember SH3BPL. Okay. Now moving forward with the etiopathogenesis, that there is a mutation in this particular gene. The normally protein encoded by this gene is function in it has a function in signaling transduction pathways and increasing the activity of osteoblasts and osteoclasts during normal tooth eruption. But what happens is the mutation leads to a pathologic activity of osteoclasts. So osteoclasts have a pathologic activation because of which there is a bone remodeling which induces inflammation. Okay, so bone remodeling occurs. This bone remodeling causes inflammation. Coming to the causes, it is a multicystic lesion. That means there are multiple cysts occurring in this lesion, and it is inflammatory swelling of the submandibular lymph nodes. So there is swelling in the submandibular lymph nodes. Then sporadic cases can also occur representing spontaneous mutation. So did you understand the pathogenesis? Basically, SH3BPL is a gene which codes for a protein, but due to the mutation in the gene, the coding changes, because of which there is a pathologic activation of the osteoclasts, in which the osteoclasts after bone remodeling induce inflammation. Okay, so that because of which there is multicystic lesion in the jaw bones. Then term cherubism, because of the facial similarity of affected children, plump cheeks. They have plump cheeks, hence they are called cherubs. Cherubs. Okay, so cherubs are cherubs. Okay, cherubs. These are the children who have chubby cheeks. Okay, and they are depicted in Renaissance paintings. Okay, that is, you just need to know that cherubism means chubby cheeks, or angel like children who have chubby cheeks. Then coming to the clinical features, age, their disease of children. So age predilection is children. Affect children at birth. So basically they have these gene mutations, gene C3, gene SH3BPL. This gene is mutated, but the mutation and the symptoms are occurring in 2 to 5 years. They are normal at birth. Mild cases are diagnosed only between 10 to 12 years of age. Stages is expansion. Initially, there is an expansion. Childhood advanced gradually slow down around 7 years. Stabilization during puberty. So first the bone initially expands and gradually the expansion slows down. Then stabilization during puberty, they get stabilized. Regresses thereafter. Coming to the bilateral involvement of posterior mandible. So the posterior mandible has a bilateral involvement. So the both sides of the mandible posteriorly are involved, causing these angelic chubby cheeks or cherubism. Okay, painless bilateral expansion is seen, involving angles and ascending rami of mandible. Okay, so involving angles and rami of mandible. So bilateral expansion is there, which involves the ascending rami and angle of the mandible. Okay, then in severe cases most of the mandible is involved. Milder involvement is in maxilla. Only the tuberosity area is involved in general cases. Then you have Grotsky expansion of maxilla leading to respiratory obstruction. So there is the obstruction of the respiratory tract and impairment of vision and hearing. So in milder cases, in maxillary cases, it is usually mild, and the affected site is usually the tuberosity of the maxilla. Then you have something known as Grotsky expansion of maxilla, which is the respiratory obstruction and impairment of vision and hearing. Then extensive bone involvement, marked widening of the distortion and alveolar ridges, tooth displacement is seen, failure of eruption, impaired mastication, speech difficulties. So what and all is seen in the extensive bone involvement? When the bone is extensively involved, we see in marked widening, distortion of the alveolar ridges, tooth displacement, failure of eruption, impaired mastication and difficult speech difficulties. A rim of circular visible beneath the a rim of sclera visible beneath the iris because of expansion involving the orbital rim. Eye to have an appearance. So the eyes have something called as eye to have an appearance, where the rim of the sclera is visible beneath the iris. Okay, so a rim of sclera is visible beneath the iris, expansion involving the orbital rim. Then there is a marked cervical lymphadenopathy, bone enlargement, and full moon face typical cherubism. Grading. Now grading is grade 1, grade 2, grade 3. Involvement of both mandibular ascending rami, involvement of both maxillary tuberosities as well as mandibular tuberosity. So grade 1 is where your mandibular rami is involved, both sides. Grade 2 is your maxillary tuberosities are involved, both sides, as well as mandibular rami. Okay, both sides. So involvement of maxillary tuberosities on both sides and mandibular rami. Here only mandible, here maxilla and mandible. Next, grade 3, McCune-Albright syndrome is involved with whole maxilla and mandible except the coronoid and condyle. So in grade 3, the McCune-Albright syndrome is prominent with involvement of maxilla and mandible without the condyles and the coronoids of the mandible. Then coming to the radiographic features, bilateral symmetry is seen, multilocular radiolucencies with expansion of both jaws. So both jaws expand and there is multilocular radiolucency. Early lesion is posterior body and ascending ramus of mandible. Early lesion involves posterior body and ascending ramus of mandible, displacement of inferior alveolar canal. So early lesion causes posterior body and ascending ramus of mandible involvement. So posterior body of the mandible and the ramus is involved in the early lesion. Then the displacement is in the inferior alveolar canal. So the resorption causes a displacement of the inferior alveolar canal. Then maxillary involvement. Maxilla is less extensively involved, and if it is involved, usually the hard palate is involved in the maxilla, and you have something called as hard palate sign. Forward displacement, absence of tooth follicles because of which a prominence in posterior part of hard palate. So there is a prominence in the posterior part of the hard palate which causes a forward displacement of the tooth follicles, because of which there is a prominence in the posterior part of the hard palate. Dental anomalies: absence of teeth, eruption failure, displacement of alveolar bone and destruction causes dental anomalies. There is absence of teeth, eruption failure, and displacement of alveolar bone and destruction. Multiple unerupted teeth with destruction of alveolar bone leads to floating tooth syndrome appearance. What is floating tooth appearance? When there is dental anomaly and absence. So basically when we see in a radiograph, what first we see is a multilocular radiolucencies in the both jaws with expansion we can't really see, but we can see the movement of the cortical, like the expansion of the cortical plates, boundaries of the cortical plates. We can see multilocular radiolucencies, and we can see posterior body and ascending ramus of mandible. Then we can also see that there is a displacement in the inferior alveolar canal. Maxillary involvement is also seen. Then we have something known as hard palate sign. Forward displacement and absence of tooth follicles. So if tooth follicles are absent, there is a forward displacement of the hard palate, and there is a part of a prominence in the posterior part of the hard palate. That is your hard palate sign. Okay, so then coming to the dental anomalies, there is an absence of teeth, eruption failure. So in the tooth socket there is an absence of teeth. Okay, there is an absence of teeth, eruption failure is occurring, and displacement of the alveolar bone resorption is also seen. So dental anomalies, what do we see? Absence of teeth, eruption failure, displacement of alveolar bone, and destruction. Multiple unerupted teeth with destruction of alveolar bone lead to floating tooth syndrome. Okay, floating tooth syndrome. Okay, what is this? We will read about it. Floating tooth syndrome is when multiple unerupted teeth are there. So basically there are multiple in the jaw, there are multiple unerupted teeth present, and there is a destruction of the alveolar bone. So there is a destruction of the bone, and you see the teeth, it looks like the teeth are basically floating in the jawbone. Later, when diseases resolve, irregular patchy sclerostic radiolucencies are seen, leading to ground glass appearance. Next, the histopath. Unencapsulated highly vascular connective tissue with numerous large spindle fibroblasts, multinucleated giant cells. So there is an unencapsulated vascular connective tissue. So there is a capsule which is not there. So there is no capsule in of these lesions. There is no capsule present, and it is highly vascular connective tissue with numerous large spindle and fibroblasts. There are multinucleated giant cells which are seen, suggestive, and these giant cells are basically your osteoclasts. So osteoclast is a type of giant cell, right? Then so these multinucleated giant cells are nothing but your osteoclasts, numerous blood capillaries. So what all we see? We see an unencapsulated connective tissue, numerous large spindle, fibroblasts and giant cells which resemble osteoclasts, numerous blood capillaries lined by cells. Okay, then capillaries lined by thick eosinophilic perivascular cuffing, characteristic of cherubism. So there is a characteristic of cherubism, that is the capillaries are lined by thick eosinophilic cuffing. Okay, then rarely areas of hemorrhage and hemosiderin pigmentation is seen. In older resolving lesions, it is more fibrous. No number of giant cells decrease, more fibrous, number of giant cells decrease, new bone formation is seen. Treatment is, because of the natural course of the disease, natural course of the disease, it ceases to expand. So the size expands because of the disease. There is no treatment except observation. Rarely surgery for cosmetic reasons could be done to correct residual jaw deformities after puberty. So these are a few images that I'd like to show you of how the jaw appears. The jaw expands and there is a destruction of the jaw bones. This is a very severe case. The child looks like this. Okay, see here there are different images of children, how cherubism looks like. So that's all for this video. If you like, please do like, share and subscribe to my channel, and for more such videos press the bell icon. Thank you so much.